Great. So everyone should be able to see that okay. Okay, let me make sure. Yeah, everyone should be able to see my screen okay. So this is obviously part two. What we're going to do in part two is a little bit of sort of some of the basics again. This whole course, Scleral Lens Fitting 101, was for people who are either brand new to fitting or people that kind of want to brush up on skills and different techniques for the basics. One of those is obviously insertion removal. We'll go through that very quickly. A little bit about solutions. It's a question that I always get asked, particularly on my social media, practitioners, oh, well, what's the best solution to use or what do you recommend? A little bit about air bubbles. Obviously that's a problem if that's in the reservoir. Midday fogging, a little bit about coatings. We're going to do a very, very quick recap. Now, this is only a few slides on basically part one. This is for people who are joining today that didn't see that first one. But also, again, if you're new, that's probably quite a useful recap. A little bit about how I document my scleral lenses, and then we're going to actually do some ordering as well. I'm going to share my screen and show you, some of the easier ways to order. Now, there is no financial disclosure. I will talk about specific lens brands, lens types, solution types in this, but there's no real preference one way or the other. And unfortunately, I'm not getting paid to talk about any of these topics. There's lots of really, really good videos online, just on YouTube. Most of them are based towards patients on how to insert the lenses and remove them. But the techniques are very similar. These are two of the more popular kind of, YouTubers that obviously delve into contact lenses online. You're probably going to want some tools, particularly in the beginning. It makes it a little bit easier. There's two sort of main types. There's obviously an insertion tool, which can either be like this one at the top. I don't know if you can see my camera, which is sealed at the bottom, or you can have ones that are vented. Basically what happens is this can create a suction, but some of the patients just cut that off the bottom. It's not very useful when you're inserting to have the lens stuck on. And then obviously just some saline. After a little bit of practice, you can go for the sort of Italian technique, where you're kind of balancing the lens on a little kind of tripod. This is a little bit trickier. If you're putting the lenses in a patient's eye, particularly if it's their first time for a fitting, these patients are going to be quite nervous. So it's a little bit easier if you can keep your fingers away and use something like one of the little insertion DMVs is what they're called online. What I'm going to do very quickly is there's two techniques for inserting the lens, and I'm going to try and show you those here. I'm just going to get my wife, Danny, to come in. And what I'll do is I'll stop sharing my screen just so you can see it a little bit bigger. Hi, Danny, come on in. Okay. So the two techniques are, the first one is, hi, Danny. So yeah, if you stand on the mark, you're going to want the patient to be as horizontal as possible. So if you just bend at the hips, come over, and you can do this either in the patient chair or outside. Ask them just to hold the bottom eyelid. Hold that. Now the headlock technique, you go over the top. Okay, so you're going to go right underneath those eyelashes, and then insert the scleral lens inside. Now for this, a bit like you're grabbing a bull by the horns, you want to grab the eyelid by the base of the eyelashes. And the second technique, so one more, Danny. So if you go down horizontal, okay, ask the patient to hold the lower eyelid. It's the proposal technique. Thanks very much. Thank you for your help. So those two techniques basically are the... Let me just start sharing my screen here again. There we go. Okay, so the two techniques, basically one, I prefer that headlock technique. The reason for that is that you have much more control over the upper eyelid. The patients are generally pretty good at holding the lower eyelid. So, just ask them to hold it at the base of the eyelashes as much as possible. Now, we have here obviously a practitioner or a patient who's used to wearing the lenses, and you can see there that the idea is to get that palpebral aperture as wide as possible just to make sure that that lens goes in as easy as possible. Now, these individuals are obviously fearless, and a first-time patient might be a little bit more squeamish. And, what you want to do, reassure them again. So I like to get my patients fully horizontal, not just their head. You want to hold the upper eyelid, get them to hold the lower eyelid. And once that lens is full of saline, the negative pressure inside will keep it attached to that front surface. This is one where the patient's sitting down. Be careful what the patient's wearing. If they're wearing like a white shirt or white trousers, you're going to want to make sure that you cover them up, at least with a tissue, if not something a little bit more robust. We use the theater gowns quite often, either disposable or reusable, for this, just to make sure that they're covered. The insertion technique, you either want to go over the patient's head, or the proposal technique where you're on one knee below. For people with a bad back, you want to probably use the proposal technique so that you're not bending over quite so much. The main thing here is to make sure that the patient's face is parallel to the ground, even if they're looking down, but their face is forward. You're never going to get that lens in without a bubble. You want to make sure that their full face is parallel with the ground. Now, to remove it, you want to use a slightly different tool. For that, we use these smaller suckers, or DMV Ultra is the technical name. But if you ask for a contact lens remover or a small sucker in the clinic, especially a contact lens clinic, they'll know what you're after. You want to aim at about 6 o'clock for this. Okay, if you aim at the very center, what happens is you just create a larger negative pressure zone. So what I mean by that is, if you've got your lens, if you go straight for the middle, all that happens is that you pull the full lens. What you want to actually do is go at 6 o'clock and then create a bubble under the lens. So by pulling it out at 6 o'clock, usually it's a bit easier. If the lens is stuck, ask the patient to look up, push an air bubble under the lens. That breaks the suction, breaks that negative pressure, and then it is much easier. And you can see a nice example. Again, this is from the Scleral Lens Education Society, this video. You can find it on YouTube. So again, you want to aim just at the sort of bottom of the iris, or sort of at the limbal zone, and it's much easier to remove the lens. You can do this without the tool, but it is much easier to begin with. And again, this is doing it on a patient. So hold the upper eyelid just to get control from the base. Get that lower eyelid out of the way. And again, you don't want to go straight in the center. You want to go just off axis for this. Over to the next side. Solutions and cleaners. This is very area dependent. So where I am, it's quite difficult actually to get a lot of, we don't really have a wide range of cleaning solutions. Some of the more common ones are, a kind of multi-purpose, something like a Eyecare Pure, Tangible have their own, or you can move to a peroxide-based system. Most patients get on very well with the kind of either standalone cleaner and storage, or a multi-purpose solution, and there's lots out there. So just see what's available either in your clinic, in your area, or in your local pharmacies. Usually the peroxide, it's obviously a little bit more tedious, and I would leave that for when required. I use that as my kind of go-to when a multi-purpose isn't working. For the saline, the only thing you really need to make sure is that it's preservative free. I mean, there's lots of different special contact lens salines out there. We don't have a lot of access to it here. A lot of them have to be shipped in from abroad. The most common one we have is the Physiologica, which is basically, just a general family. You'll find it in most supermarkets here or pharmacies. It's just a general saline that's preservative free. The Adipac Lacropure Sclerofill neutrophil. These ones are always very expensive, and usually they'll be shipped in from the United States most of the time. There are some specialist practices in the UK that offer them, but most of the time they're shipped in from abroad. As I said, some of those specialist solutions, the Adipac, the neutrophil, can be useful. They have, electrolytes baked into the solution. It's supposed to be a closer pH to the surface of the eye. Um, and as a result of this, there's less midday fogging. The patients, in some studies, have reported better comfort. But honestly, most of my patients get on very, very well just with the standard saline. With an air bubble, it's really important to distinguish, is this an air bubble that was introduced because of how the lens was inserted? So was it inserted maybe slightly off axis? Or is this something where the bubbles are leaking in, where the scleral lens itself isn't sealed? Now, what will happen if there is a bubble under that lens? The reservoir, the lens itself will be lifted off the eye because obviously you've got a bubble underneath. It will increase that central clearance. So quite often what you find is once you remove that bubble, the lenses settle a little bit lower. The easiest thing to do in clinic is whenever you're inserting with the saline, just put in a thick artificial tear, something that's preservative free, obviously. Celluvisc, Artilac, I mean, there's lots out there. Even if you go for something like, if you've got a bottle of Hylo gel that's open in the clinic, again, that's preservative free. You want to make sure it's thicker for two reasons. One is the patient's less likely to spill, or you're less likely to spill out some of that reservoir needed. But the other thing is that because it's a thicker solution, it'll rest in the bowl easier and push out any of those insertion bubbles when you're doing that. If the patient's very difficult, you might need to use a mild anesthetic, a proxy Medicaine, oxybuprocaine, something like that. But more often than not, because the patients can't see the lens itself because it's so close, usually it's not needed. And as I said, these scleral lenses are generally really comfortable, so the patients are happy. Midday fogging. Now, people give full lectures on this topic. Um, so I'm going to try and sort of briefly go over what is it and what are some of the potential tools that you have to work against it. You need to figure out, first of all, is this a blurring of the front surface of the lens? Okay, so that could be from either solutions, lid hygiene, MGD, facial products. Um, we in one of the group chats there was a patient that was doing ghee therapy where they're putting ghee on their eyes. Obviously, anything like that with a contact lens is going to be really, really greasy. They're not going to see much through that front surface blur. Or is this something that is in the tear reservoir? Now, obviously, you'll figure this out pretty quickly from the slit lamp. So, what you can see here at the top is a greasy front surface. Now, that'll be changing as the patient blinks. In the second photograph, you can see here some debris, some accumulation of particles within that tear reservoir. And that's a very different type of midday fogging to the front surface. What's this from? It could be from maybe there's too much clearance there. It could be that the eye is irritated, upset, inflamed. It could be that sometimes if the lenses aren't sealed properly, it's sucking in that mucus layer from outside. The external conjunctiva that's not covered. As I said, there's quite a few things that can cause this, but what do we do to try and resolve it? Regardless, anything that's inside that internal fogging. We really want to make sure that the lenses are deep cleaned. Quite often what you'll find is that the lenses themselves have either debris buildup on the inside of the lens. And again, they're quite deep. So you might find that the back surface isn't being cleaned properly. So I would do a deep clean with a cotton bud. You can change the lens material. Some people are a little bit more reactive to some than the other. Change the solutions. If I find this, one of my first things to do is to go to a peroxide-based system. So that just removes any of that multi-purpose solution that could be causing it. Review of their skincare, their cosmetics. Are they using a lot of, greasy, oily skin products around the eyes? Obviously, you can go to this neutrophil, scleral fill, these more, let's call them exotic filling solutions. And then, you've got other things like alcohol-based cleaners or Hydropeg that can help as well. This is all the internal, mostly the internal debris buildup, and I'll show you just a video of that next. This was a patient I had a while ago. Usually this midday fogging that's in the reservoir comes on after a period of time. So usually they'll say, my vision's great up until 4 hours or 6 hours, and then it starts to become problematic. If there is any ocular surface disease, you want to treat that. I'm very pro giving someone as an azelastine or an ectoin drop. One of my favorites is Hylodual. Again, because it kind of kills two birds with one stone. The eyes are getting hydrated, and you can put this inside the lens, or you can put it on top as well once the lenses are in. But something like a Hylodual kind of hits it from two parts. If the external part of the eye that's not covered is drying out, becoming inflamed, irritated, that will increase the debris. So the actual dry eye component will help. But if it's maybe a mild allergy, here specifically, we have a lot of dust from AC. At home, the main issue was hay fever, which a lot of these keratoconic atopic patients have. So you want to treat that atopia, as well as obviously the vision as well. And then once the fitting's good, you've tried to change your solutions and you've tried, to optimize uh, every aspect of it. Sometimes these patients just need to replace their lenses during the middle of the day. And as I said, if there's any issue with the fitting, you can go to these kind of more customized quad specific lenses or the impression lenses. Hydropeg came through from a company called Tangible. Now they work with Optimum primarily. That's basically there's two materials that Hydropeg, which is a surface coating, is able to be used on. One of them is Optimum, and the Optimum materials in that. And the second one is Hexa 100, but that one's not really used quite so much. Um, this coating came out in 2016. It got FDA approval. I think we got it in the UK a year or two later. But this was hailed as, the revolution of the century. The best thing since Keanu Reeves. This is going to solve all of our problems. Does it? This is basically straight from the marketing material. It improves rewettability, and it definitely does that. The surface is a lot slippier. As I said, lubricity. There's less deposits on the lens. This increases comfort. Doesn't change the lens shape at all. So all this does is keeps more moisture on the surface. One of the initial studies was actually done where they took an Oasis lens, dehydrated it, removed any coatings, and then basically put the Hydropeg on top. I don't know why they done it on soft lenses, first of all. I guess it's much easier to kind of look at the drying pattern on a soft lens. There are other studies out there. Most of them seem to suggest that, a coated lens dries out less. There's less of these kind of dry spots, dry patches. And, moving from left to right, this is basically post blink. And then on the right hand side, you've got 10 seconds where the patient hasn't blinked. And the surface isn't breaking up quite so much. Do I get all of my lenses treated? No. It depends patient to patient who I think it'll be useful on. If I've got someone who I think has, quite a lot of dryness, maybe potentially going to deposit a lot on the lenses, quite a lot of MGD, yes, I will get it straight away. The issue with Hydropeg is that it is a coating at the end of the day. It is something that will wear off over time. And as a result of that, you have to use either their cleaning solution to, rebuffer that surface coating, or you can send it back for the lenses to be recoated. Now, they're very, very strict on what solutions are able to be used. Here, you've got some of the more common ones: Medicare Pure, Boston Simplus, Total Care Cleaner. Quattro is another very, very common cleaner that you'll see in a lot of practices. And these are pretty much widely available in most places. The other option you can go to is a peroxide system. If you're not sure of any solutions, just look on their website. Type in HydroPeg solutions list. You pick your country or your area, and it tells you what to use, what not to use, and alternatives. So as I said, peroxide system here is something that I go to as a backup when the multi-purpose isn't working. And there's plenty to choose from there. The big no-nos, the ones do not use, is obviously tap water, for infection reasons. But anything that's abrasive, like a Boston cleaner, so that's the Boston Advanced, the one with a little brown lid, or anything with alcohol-based systems as well. Now, the Boston with a brown lid is very common. If you see RGP patients, especially if they've been fitted on the NHS, you know, 8, 9 times out of 10, they'll be used to using Boston cleaner because it is very abrasive. It polishes the surface somewhat as well. So just be sure if you're ordering a lens with HydroPeg, ask the patient, what are they on at the minute? Are they happy with that solution? Or are they happy to be changed to something else? This is going to be a very brief recap of the initial lecture. There's only about 5 slides here, but we have talked quite a lot about these different fitting zones. So obviously you've got that central fitting zone. That's where we're editing the sag of the lens, the depth. And the primary reason for that is this kind of central clearance between the lens. Sorry about that. Between the lens and the corneal surface. Each of these changes that we're going to make today will be done on this lens, which is a one fit lens from Blanchard. And you can see there that you can either plus means to move something further away from the ocular surface, minus means to move something closer. And that can be that central sag, mid-periphery, limbal area, or even to the edge or the haptic. This is an example here where you maybe have a little bit too much clearance in the center. Maybe the mid-periphery is good. Maybe you want to adjust the mid-periphery a little bit, slightly further down. And as I said, this is something that we will go into in the cases after. Limbal clearance, you really want somewhere in the region of 75 to 125. You're going to want more clearance, obviously, centrally than you will moving towards the periphery of the lens. Centrally, you're looking at about 300. That mid-periphery, maybe 150, 200. And then at the limbus, you want to make sure it's definitely clear. So there's definitely fluorescein under that lens. And again, you're aiming for kind of 75 to 125, somewhere around about there. Normal changes will get smaller as you move out towards the edge. If you change the sag in the center, it will have slightly less effect overall. So that's why these changes at the edges are quite subtle, especially whenever we are trying to go for this kind of 50-50 ratio that we discussed in the first lecture, where you want that lens having pressure on the conjunctiva, making sure it's sealed, but not excessive that there's blanching underneath. And then we've got this heel touch, and the heel touch is where the lens rests just before the edge. So this is where there's an area of blanching here. This is heel touch. Whereas toe touch is a little bit different, where the very edge of the lens is what you can see here, kind of digging in around the periphery. Heel touch, toe touch. And both of these are examples of the edge being too tight, but just in slightly different areas. Again, you're going to want to do an over refraction at the end. Make sure you note which lens you're using. Make sure you note the trial lens, the prescription of that. I always recommend an auto refractor. I find it so useful for seeing what movement is happening with that lens. It gives you a good place to start for a refraction as well. I mean, obviously you can use your ret as well, which is super useful. But you want to make sure that that over refraction is both sphere and sill. Okay, and we'll come on to why that's super important after. Go back to the kind of one of the newer stuff now. So what is the scope study basically looked at 8,000 fits from various different practitioners across the world, and the most commonly fitted diameter of scleral lens was 15 to 17 millimeters. That's what's kind of in vogue at the minute. Some people like to use smaller, some people like to use slightly bigger lenses. The one we'll use today is about 15.6 millimeters, 15 and a half roughly. But that's where most people are fitting today, between 15 and 17. Why is that? I mean, previously people fitted much bigger scleral lenses, then everyone moved to RGPs. People are moving back now to scleral lenses. And initially the lenses were quite small, 13, 14 millimeters, something like a number 7 ICD. But now they're slowly creeping up and we're getting slightly bigger lenses on the whole. The scleral shape study group. So what was this? Essentially, there was a group of practitioners, and this is a really great paper. If you get a chance, take a photograph of this. I even have it in a nice little purple glow just to show its importance. But basically what they'd done is they looked at 140 eyes. They took OCTs of the anterior surface and basically looked at that 16 millimeter chord. So that 16 millimeter circumference, if you will, and basically plotted out what's the different sagittal depth at each degree. So you can see here on the graph, it goes around to 360 degrees, and you can see the difference in the depth. Now, whenever they were sort of divvying up these patients, they had to denote it as, is it a spherical landing? So is it spherical around the outside at the 16 millimeter quadrant? Is it toric, where a bit like with the rule and against the rule astigmatism, where you've got a steeper meridian and a flatter meridian? Or is it quadrant specific and a custom lens needed? Now, how do you say what goes from a spherical lens required to a toric lens? Now, their cutoff was 300 microns. So basically between the two flattest meridians and the two steepest meridians, they decided that 300 microns moves an eye into that should have a toric landing contact lens. If those flat and steep meridians aren't at 90 degrees and 180 degrees, then they recommended something that was a customized lens or a quadrant specific lens. As I said, these are what they found. So basically there was only less than 6% of eyes were uniform and had less than 300 microns difference across that 16 millimeter chord just outside the limbus, which is quite surprising considering how many people start fitting a spherical lens as their first lens. I mean, it's sort of the equivalent of you wouldn't refract only using spherical lenses, because we know that the eye has two different meridians. But I thought that was quite interesting. If we move that the goalpost a little bit, and instead of using 300 microns as the cutoff, if we use 150 microns as the differentiator, the spherical eyes go to 0.7%, and obviously the other ones take up that that slack and they increase a little bit more. I guess the next question is, Zach, what are you talking about? These kind of toric sclera. Well, as you can see here, obviously we've got an eaglet, a map, where you've got the cornea in the center. And again, it looks like it's flatter, sort of with the rule of astigmatism. But the eye itself also demonstrates that. So outside the limbus, you have a flatter meridian here. I would assume there's maybe some pinguecula or thickening. This looks like the nasal side, but it's much flatter here than it is across that, 6 and 12 meridian. 3 and 9 is much flatter, and that's normal, These landing zones, if we make the lens toric to begin with, it gives us fewer areas of localized pressure. Obviously, you're much less likely to get in bubbles because the lens itself fits better. And these patients generally are a lot more comfortable. The issue is that if you fit a spherical lens, what's going to happen is that the lens will sit off. Okay, you'll have edge lift, usually at the top and bottom, okay, because they're the steeper meridians. As a result of that, the patient's going to feel it every time they blink. As you move further away from the center, so if you go for a smaller lens, you're going to need less toricity. So a 15 lens, you might want 150 microns of difference. 16 or 17 millimeter lens, you might want 200 microns of difference. And this is backed up by quite a lot of studies. What happens if we fit a spherical lens? What's one of the issues? Well, the lens itself is going to flex. So every time the patient blinks or moves their eyes, that spherical lens is going to flex, obviously causing a distortion in vision. The lens is going to rotate, obviously, because it's got nothing to hold on to. And it's going to decenter slightly more as well. So, these scleral lenses that fits or should fit better. Once you're at that 15 to 17 millimeter mark, you're going to want a lens that is at least in some way stable on the eye, is in some way matching up to those flatter meridians. Um, as I said, 15 to 17 millimeters. If you're fitting a toric lens, I would start with something that's at least 100 microns, with the bigger lens, 200 microns of difference between those two. So if you're not picking up at the minute, I'm a big fan of starting with a toric contact lens to begin with. If you do not know um, if you do not have that scleral shape, if you don't have these fancy tools for measuring it, like we discussed in the first lecture, put on a toric lens, and it'll be a much, much better starting position. What way are we expecting these lenses to sit? As I've said before, we're expecting the flattest meridian to be at 3 and 9, but that's not always the case. Basically, what I'm showing here is that the angle of insertion, so the angle to the conjunctiva and sclera, is a little bit flatter across the horizontal. So on average, it's kind of 35 degrees, 37, whereas it's 42 and 39. So it's much steeper, superior and inferior. These markings, it's much the same as you can see with the soft lens. There's some here. It's a bit easier to see sometimes if you put in some lissamine green or some fluorescein. This one's at the top, but obviously these ones are a little bit closer to the horizontal. I'll just highlight that there for anyone that can't see those markings. Why is it flatter across the horizontal? It's probably because of the extraocular muscles. Their insertion is a little bit closer, obviously at either side. At 3 and 9. That's one of the theories anyway of why where it's a little bit flatter in that axis. The drawings that we discussed at the start, the reason why I put those horizontal markings, for example, this patient, sorry, that should be 0, 90 degrees, 3 and 9 o'clock. This is how I would write if the lens axis is along that horizontal meridian. If the axis is off, obviously you're going to measure that. It's a little bit easier with the slit lamps that have the top-down illumination, or something that has a graticule on it, because you want to really accurately measure what's going on here. I write it in two ways. So I will write it from the horizontal, so that'll be 135 degrees. But I will also write the clock hour as well. The reason for that is that we're measuring this to the horizontal. And you can just use your Lars or CAS or whatever soft lens, whatever kind of, left add, right subtract, whatever type of acronym that really helps you to remember. And then you can just go onto their website. There's plenty of these RX calculators. This is the one from Blanchard, the one whose lens we're going to discuss today. It always measures to the horizontal. So for example, if that lens is 20 degrees off, I would write 20 degrees, 10 o'clock, and 4 o'clock, okay? It means that there's two ways I know exactly how this lens is fitting. So I need to know, is it 20 degrees at 10 o'clock, or is it 20 degrees at 8 o'clock? As I said, we're expecting this to be along the horizontal. Let's talk about a case example here. Now, what I want you to do as we go through here, just be making some notes on the lens itself, okay? But I'll tell you kind of what we're going to note down, what we're going to talk about. This patient, 24-year-old male, first-time wearer, had cross-linking a year previously, and we're going to put them in the kind of moderate keratoconus category. What is that? As I said, the diopters, K readings aren't super relevant because we're not fitting the cornea per se. We're kind of fitting the sclera. But let's say this patient's 55 diopter cornea, something kind of moderate. The trial lens, we're going to use a 1-fit med from Blanchard. What do I write down in my notes? So I'm going to write obviously the type of lens, a 1-fit lens from Blanchard. The trial lens sag, the depth of the lens is 4,300, diameter 15.6 millimeters. That's just straight from the trial set. The toric edge, so this is a toric lens, meaning that if there is a reference plane, there's going to be one meridian that is slightly flatter, so slightly increased in that horizontal. And then a slightly steeper meridian. So the difference here in the toricity between one meridian, be that between 12 o'clock, 6 and 3 and 9, the difference is 150 microns between those two meridians. And as we've sort of seen from the literature, that's what we expect. But also actually anecdotally, I looked at about 250 of my fits of what I'd been ordering just to figure out with this specific lens, a 1-fit lens, what is the most common difference in sag that I order, and it is 150 microns at that 15.6 millimeters. The last thing we want to note is the power, again, the prescription of the trial lens. We put in the trial lens, no bubbles, success. But what we've got here is obviously quite a lot of compressive visual contact. How do we know that it's compressive? Well, there's no fluorescein under that apex of the eye. We know that it's quite focal contact and not very gradual feathering or light touching of the back surface and the cornea. The reason for that is that there's a very, very clear edge that you can see on this. If that edge is very feathered, it means that the fluorescein is tapering off gradually. If you find that it's very abrupt like this, what you're happening is that focal point of contact is pressing hard against the back surface. So with this lens, what are we going to do? And again, you're going to want to write this just in the notes. You're going to want to increase the sag at least 300 to 400 microns just to clear that cornea. Then you're going to want another 300 microns of clearance, that ideal clearance. The other thing you'll find with this lens, I just want to note, is that when the patient blinks, you'll find that the fluorescein still doesn't go under or between the eye and the lens. Now, if it's a very gradual and it's lightly touching the back surface, blinking will push some fluorescein underneath, and you'll find that the fluorescein pattern will change if it's very close to fitting. But this one will need at least kind of 600 or 700 microns of increase in that depth to get clear. This patient probably has fantastic vision. If this is someone that has never worn contact lenses before, and you're crushing that apex, you're flattening the cornea, and this patient's probably going to have great vision and not want you to take out that lens. But obviously this is unsustainable. So for the second lens, we're going to go up to 5,000 microns of sag. Diameter is the same, edge is the same, and the prescription is the same as well in this example. So we've got some clearance, which is great. So what I would just write, central clearance. We can measure it here. It's probably somewhere around about 300 to 400 microns, which is good. But what you have here is a lot of mid-peripheral excessive clearance. And you can see that, around the mid-periphery here, there's a lot of fluorescein under there, and that's going to cause that lens to drop down, as you can see in the example. So this lens is starting to lean forward. You've got too much here. So central clearance is good, 300 microns, maybe a little bit more, 350, 300 microns. The mid periphery is a bit excessive, so we're going to remove 50 microns of that mid periphery. We don't want it too close, but we want to centralize that lens a little bit better. Once we move over to the limbus, if we go a little bit further down, that mid periphery we're going to reduce, but the limbus is fine. So we've got about 100 microns there. So again, the second lens, we've got 5,000 microns, edge, prescription. The only adjustment we're going to make up to this point is we're going to reduce that mid periphery slightly. We want to look at the edge. So what's going on with this edge? Oh, let me give you a photograph for reference. What you have here is this is the axis, which isn't quite sitting at the 3 and 9, the horizontal meridian as expected. What you've got here is you've got about 10 degrees of the lens offset. So 10 degrees, and again, it's sitting at 4 o'clock, 10 o'clock. We'll make a note of that. The other thing you can see here is once we're shining our slit lamp beam across, there's a little shadow just under the lens. Now that shadow's only in the flatter meridian. Now that makes perfect sense. The reason for that is that the lens is going to be more off the eye, okay? A flatter lens will sit off slightly more at the edge. So this flatter lens in the flatter meridian, what happens there is that you're getting this shadow, and we're going to want to reduce that a little bit. How are we going to do it? Well, we're going to go back to our diagram before of the change. This is what we call heel touch. The reason for that is that the lens pressure zone isn't at the very edge. It's a little bit before that. And as I said, that heel touch versus toe touch is where it's at the very edge of the lens. This is a heel touch. The changes we're making 75 microns. Now that's a clinically significant step for something like a small shadow or a small irritation. What have we adjusted? So we've adjusted this mid periphery by 50 microns. So we have reduced that slightly. The edge itself, again, we're going to do a minus. So we're decreasing that edge to bring it closer to the ocular surface. So again, we're making a small adjustment to the mid periphery. We want to note the axis. And then we're going to, adjust this flat meridian. The steep meridian's a really good fit. And again, just to reiterate, how do I know it's the flatter meridian? The flatter meridian in this lens is shown quite clearly by the markings. We have an over refraction, patients over the moon, they're getting 0.04 vision with no shadows. Usually it's something that I quite like to note if there is any shadows or distortion. It's just something quite useful to look back on instead of just the number itself. The actual quality of the vision is really, really useful to know as well if you can. Some type of, how is your vision, any issues, any problems. Now that we have all this information, okay, I want you should have been kind of noting some of these down as we go through. But what we'll do next is we'll just quickly note down. So it's a lens with 5,000 sag. We know that that edge is at 10 degrees. The prescription's -1. Edge is +75, -75. That's the standard one from the trial lens. And the only adjustments we're going to do is that mid periphery. We're going to reduce it by we're going to reduce it by 50 microns. Great. So let's actually go through and look at an example here. Let me see if I can just close this down. If you just type in the Blanchard, this is what you should have been noting it down on. With the website Blanchard One Fit, let me just show you. I'll make this a bit bigger. Product. So which lens we're using today? We're using that Blanchard One Fit Med. That's their kind of standard. So Blanchard One Fit, Blanchard One Fit Med. Here we go. They have a plus, which is a little bit bigger diameter. Tools in order form. You're going to want to open, there's two different tabs here. I'll go back to One Fit Med. You're going to want to order the fitting tool, okay? And then this custom tool as well. Now the fitting tool we're going to go through here. Standard diameter that comes with the lens. The sagittal depth we had was 5,000 microns. Again, the mid periphery was standard, the limbus was standard because it's from the trial set, and that prescription was -1. What changes are we making to this lens? We wanted to reduce the mid periphery by 50 microns. Now you've got the edge, we're adjusting the flat meridian by 75 microns. In what way are we adjusting it? So as I said, we're making it steeper. We're bringing it closer. So we minus 75, the flat meridian's already plus 75, so that goes to standard, and we're not doing any changes to the steep meridian. Our over-refraction was minus 2. Spherical component, we'll come on to the toric component after. And the tool basically does all the hard work for you. It'll make the calculations here of your sag. It shows you what's the difference. So in the flat meridian, we're adjusting both the mid-periphery and we're adjusting the edge. On the steep meridian, we were only making an adjustment to that mid-periphery. It tells you the center thickness of the lens. It tells you the prescription. You're probably going to want to round this up or down depending on the patient. And as a result of that, we're just going to fit the right eye today. It prints you out the order form already, which is fantastic. You're just going to want to pick, sorry, just going to want to pick this. Let's give the patient -4. He's a young guy, so he can do that little bit of accommodating. Now the front surface, if you remember, the over-refraction was -2, -125 at 80 degrees. So we want to incorporate that because that's what he needs to get the good vision. Now the sill was -1.25. What was the axis? In your custom tools here, and even though I do the left add, right subtract in my notes, I will always go on here and just double check. The over-refraction was 80 degrees, the axis. That lens, if we remember, was sitting at 10 degrees, which means that the compensated axis we're going to want to order is 90 degrees. Okay. And again, this tool lets you, place where the lens is and make the appropriate adjustments at 10 degrees. If it's multifocal, if there's materials you can pick, if you want hydropeg, and you can note that down. Okay. Now let me just go back here. So that's kind of one very, very quick example. We're going to do one more as well. I know that we're probably going to run over time a little bit today. But good. As I said, you're going to want to put your trial lens at the top and your changes in the bottom here. You'll get a really nice example of, like the one we just went through. And as I said, double check the toric markings. Usually with a soft lens, you're used to those markings sitting at 6 o'clock. Here, we're used to them sitting at 3 and 9 o'clock. Just double check that before you order the final lens so that you're not ordering it 90 degrees off axis. And yeah, here's your final lens then. I always keep this. Obviously, I'll send this to the manufacturing lab, but I'll also have this obviously stored in the patient notes as well. Once you remove that lens, make sure to check that it's the lens that you think it is. I could not make that any more clear. This is something like what my notes would look like. Sag, diameter, the adjustment I made to the mid-periphery, limbus is standard. Standard edge, sorry, that should have been 75, not 150. The overall prescription, which is calculated by your adjustments made. Also note where you expect the axis to sit. The reason for that is once you go and put back in the lens, you're not expecting this lens to sit at 3 and 9 o'clock. You're expecting this lens to sit at 4 o'clock and at 10 o'clock. I'll just do one more very quick example that we can go through, and then I can take questions at the end. 35-year-old female. You can see here there's a little bit of an apex at the top. Cross-linking 5 years ago, and again, we're in that kind of moderate keratoconus. There is a little bit of scarring centrally with this patient, and you can see there, once we're looking at it from the temporal side, that there is quite an apex on this lens. We put in the first lens. Now, on general overall observation, we went for the same lens, same trial lens, 4,300. It's a good starting point generally. Overall, that looks quite good. On closer inspection, what you find here is that over that scarring, that little steep apex, the lens is actually sitting quite close. So in your notes here, or in my notes, I'd write something like 100 microns clearance over apex, generally 250 to 300 clearance around the other central portions. Mid periphery, 150 clearance, which is great. Am I going to make any changes? Yes. I'm going to have to lift up the sag. Now that will give me a little bit more clearance on in the rest of that sort of central optical zone. It will give me probably a little bit more mid-peripheral clearance, but I need more over that apex because this lens is very likely to settle. So what happens after 20 minutes with the lens being in? We've got 250 clearance over the apex, which is great. A little bit excessive in this mid periphery and sort of overall that kind of central exterior central zone, we'll call it. And then the limbus is, we've got too much at the limbus there. You're going to get a lot of debris and problems. Again, this is our trial lens. After 20 minutes, these are the changes that we just discussed. What's next? Obviously, we want to look at where this lens is sitting. Now, the adjustments we're going to make here, mid-periphery, we're going to reduce by 75, limbus, we're going to reduce by 75. The reason why I picked those numbers, overall, this is a lens only been in for 20 minutes or 30 minutes. It's probably still going to settle a little bit. This lens is now sitting nothing horizontal, no markings. Once we go looking, we find that the markings are at 12 and 6. So this lens is 90 degrees away from where we expect it. It's at 6 and 12 o'clock. This is something that you're really going to want to note because this will affect your over refraction. What changes are we going to make? This shadow or this sort of irritation felt by the patient, once you look, you can see that there's not a full edge lift, but there's definitely a little bit of an excessive edge around the whole periphery. And that's why we've got here 75 microns shadow, 75 microns. So we're going to want to reduce this whole edge. What do I mean by reduce? By reduce, we mean closer to the eye, closer to the ocular surface. Again, so these are our notes here. So initial lens was 4,500. That prescription was minus 1.5. Mid periphery, we want to reduce by 75. Limbus reduced by 75. And again, that axis, we've got it at 6 and 12. Edge, we're reducing 360 degrees by 75, or we're reducing the steep and the flat meridian. Over refraction, -2 with a -225 at 60. Okay. With these patients, yes, you've given them a smooth ocular surface, but I think you're almost doing them a bit of a disservice by not checking for a cylinder or astigmatism at each of these appointments. So that's something I really want to make sure you're checking for. Obviously, it's a lot more difficult with an RGP to implement a front surface toric with the astigmatism, but with the scleral lens, it's really easy once you've got something that fits well. Again, we go into the fitting tool. So our lens sag was 4,500. This was all standard. The reason why this is basically what lens is in the eye, be that the trial lens or their current customized lens. So if they come in for an annual appointment, I can put in here what they're wearing and then adjust from that reference point. You don't always have to go back to a trial lens as a reference point. That initial trial lens was -150. And as standard, the trial lenses are 150 microns difference, plus 75 in the flat from the reference meridian, -75 in the steep. What changes were we making? Mid-periphery, we had -75. We're making that a little bit closer. The limbus, we're going to reduce that by 75 as well. You can put on here quad limbus values if you only want to adjust one, but this is a fitting contact lenses 101 for scleral lenses, so we'll keep that spherical. It's a bit easier. What adjustments are we making? We're reducing both of these, steep and flat meridian, by 75 each. So this one goes to standard. The steep meridian will go to 150. And our over refraction spherical value was -2. Now let's calculate that. And here, take a pause, really consider, okay, what changes am I making? In the flat meridian, I'm adjusting the mid-periphery, I'm adjusting the limbus, and I'm adjusting the edge. And again, I'm making the same adjustments in both areas, so both the flat and the steep. looking through, that's the side we want. The prescription, because we're adjusting these mid-periphery and limbal curves, it throws the prescription out a bit. A young patient we have here, you're probably going to want to give them -5.25. So let's make sure that that all tallies up with what we're expecting. Oh, sorry. The one thing I did forget, which I can just go through here quickly, we've got left add, right subtract. So you're going to want to put in the astigmatism axis, which was 60 degrees for this patient. You rotate this to 90 degrees where you're expecting to see the lens markings. And now your new axis for where you're going to want to order that compensated lens is 150 degrees. It comes out with the order forms. We've got here -525, we round it up. Cylinder axis 225 and that new compensated axis. And again, when you're writing your notes, make sure to write where you're expecting this lens to sit finally. If you have more questions, please write them in the chat. I'm going to hang on a little bit longer today because we're sort of right up to the last minute. And there was quite a lot of information there. Please feel free to reach out. Obviously, the easiest one's kind of social media, but you've got my email there, LinkedIn, and I'm more than happy to hear from any of you guys, be that new fitters or experienced fitters. If you could follow along, my current journey with fitting contact lenses in the Middle East. I'm going to be posting a lot more case studies on there, tips, tricks, and yeah, it's always great just to network with other people in the field.